Good evening, everyone. Welcome to the American Lung Association in San Diego Community Connections series. My name is Tim Morris. I am a member of the American Lung Association's Mission Committee. And the Mission Committee is a group of interested healthcare professionals who are helping the American Lung Association accomplish its mission throughout San Diego. One of the activities that we in the Mission Committee have undertaken is the community connections that you're currently seeing now. The community connections is our attempt to make a direct connection with you, almost like we're coming to dinner at your house and having an informal conversation about various medical topics that we think would be of interest to you and would help promote lung health. I would like to thank the Sharp Health System for their generous support and the Yahavim Tam San Manuel Nation for supporting the Community Connections series, including today. This series, the topic today is going to be asthma, and that is in response to feedback from the American Lung Association Lung Health Action Advisory Committee, which is a committee made up of people from community leaders throughout the San Diego who have taken their time to work with us to try to come up with a series of educational presentations that we think you would be interested in. This presentation today and other presentations in this series are available on YouTube. And there's a link on the title page there. If you just look right underneath where it says Thursday 5:30 to 6:30 p.m., that link right there will take you right to these YouTube presentations. And perhaps we could also put that into the questions and answer as a statement there, so everybody can read that. So I would now like to introduce our speakers for today. We have two wonderful speakers and experts in the field, Dr. Tantisira, who is the chief of the Pulmonary Division at Rady Children's Hospital, and Dr. Micheal Welch, who is a prominent allergist in the San Diego community. Both of them have extensive decades of experience with in dealing with asthma, and they're here to walk us through things you should know about asthma. So could you advance a slide, please? And I think Dr. Tantisira, you're going to be first.
Yes, thank you. And so Dr. Welch and I will just give you a brief overview of asthma and some of the things that we find very interesting that we think you should know, and then obviously spend a lot of time with questions and answers. And to start, I love history, and I hope you do as well, but asthma has actually been around for a long, long time. First description was actually about 2600 BC from China, where they mentioned respiratory distress with wheezing. And if you look at the right-hand panel, the first actually therapeutic description for asthma came from ancient Egypt, about 1500 BC in Egypt, where they described actually smoking henbane plants for alkaloid benefits. And then the first description of the word asthma itself came from the Greek philosopher Hippocrates around 400 BC, and at that time he called it asmino. In Greek, that translates to panting or gasping. Next slide, please. So, what is asthma? I think a lot of people tend to describe asthma, and I like the term, like it's like breathing through a straw. You can see on this slide, basically the normal airway, your airway caliber is nice and wide. And the asthmatic lung actually does look like it becomes a little bit of a straw. And the reason it becomes a straw in the normal asthmatic airway, you see that there's actually a lot of swelling around the airway. We call that inflammation but just really a lot of swelling that makes it narrowed. When you are also triggered by any irritation, either during an attack or sometimes during exercise or other exposures, you can also have muscles around your airways that further tighten and make your airways even narrower. And so you can see that on the right-hand panel on the bottom. Next slide, please. So this is just a graphic about a lot of interesting aspects of asthma. Overall, asthma affects about 300 million people worldwide, and in all the pictorial things on the left-hand side really are United States statistics. And you can see that it affects over 28 million Americans with asthma, and of that, approximately 1 in 12 school-aged children have asthma as well. It costs the country about $82 billion annually in healthcare costs overall. And, while death is pretty uncommon, only 3,000 or so deaths per year of the 28 million people with asthma, it unfortunately can happen that some severe asthmatics can go on to die. Um, about a third of asthmatics, actually, adult asthmatics, miss work as it relates to asthma on an annual basis, and there are approximately 13.8 million missed days of school in school-age children. There's also about 50% of adults that actually report that there are some cost constraints in terms of their ability to manage their asthma. And when Dr. Welch talks about this a little bit later on, about 50% or so of patients have difficulty actually using the inhalers that are prescribed. Now, when we look at California and local San Diego statistics, at least I'm speaking from San Diego, there are about 6 million individuals in California with a diagnosis of asthma and about 412,000 in San Diego with approximately 75,000 children with asthma. Next slide, please. So, in addition to knowing those basic statistics, asthma doesn't necessarily treat everybody equally, unfortunately. And these are the sicker type of asthmatics, the ones that required hospitalization in San Diego County. And this is just basically a rate, overall rate, about 41 hospitalizations per 100,000. And you can see that the split between males and females is approximately equal, with slightly higher hospitalizations in females. When we get to race and ethnicity, however, there's a substantially increased risk of hospitalizations in African Americans and approximately a doubling of risk of in those self-identified as Hispanic compared to white Americans. Next slide, please. This also affects different age groups. Asthma does tend to be primarily, in terms of its severity, a disease of children, and you can see that the hospitalization risk rates are much higher for children than adolescents. And then there's a slow increase in trend towards hospitalization as you get older throughout the ages. Next slide, please. So, one of the things that we like to say in general about asthma is you can have asthma and you can live a very, very full life. And I like to tell my patients that with good asthma control, you can basically achieve anything. And this is a great example slide to say that these athletes have really achieved the highest peaks of their sports while having asthma as an underlying diagnosis. For instance, Tony Gwynn, a baseball player and our local broadcaster, has asthma. Novak Djokovic, the famous tennis player, has asthma. You can see David Beckham, playing soccer, has asthma. Paula Radcliffe, who's a marathon runner, and a variety of Olympic gold medalists, including Greg Louganis, Jackie Joyner-Kersee, and Michael Phelps. And then finally on this list is the Hall of Fame pro football running back, Jerome Bettis. Next slide, please. So, how does somebody know that they might have asthma? Asthma is actually characterized by symptoms with cough and wheezing and shortness of breath primarily. It does tend to run in families, and there are associated conditions that make asthma more likely, such as if you have hay fever or eczema. And sometimes we end up clinically giving what we call a therapeutic trial to say if you respond well to asthma medications, it is likely that you do, in fact, have asthma. Next slide, please. So, the triggers for asthma include dust, Pollen, animal dander, mold, viral infections, air pollution, change in weather, exercise, and irritants. And unfortunately, I wish this GIF were working. It worked in practice where it was meant to show that flowers are being inhaled and the airways collapsing on down. But apparently that slide is not working for me right now. So next slide, and I believe Dr. Welch is going to take it from here for the rest of the overview.
All right, thank you, Dr. Tantisira. That was excellent. The overview of what asthma is and the importance of inflammation, the possibility that you can be hospitalized. So, where are we in terms of state-of-the-art treatment for treating this very common and important disease? And I've listed here a number of items that patients can take on as ways to treat their asthma. And comes very similar to what you can find on the American Lung Association website, which has a wealth of information in terms of asthma and treatment. So I definitely would like to refer you to that. But first and foremost, of course, is to avoid your triggers. If you can, sometimes they're not doable, but a good example of two that would be something like cat allergy, and if that's playing a role in someone's asthma, that certainly can be avoided with proper measures. And then tobacco smoke, which the American Lung Association has a lot of information on their website to help you with how to deal with smoke exposure. So that would be first and foremost. Avoid what triggers you as the starting point for your treatment plan. You need to understand what the disease is. Always, knowledge is key in controlling any condition you have, any disease. And again, I refer you to the ALA website. Seek the best medical care you can. If you're not comfortable with the care you're getting and you feel like you can do better, you probably can. And there are a number of asthma specialists that can be found in the Southern California community. So seek them out. And once you do have that treating provider, make sure you're making your visits, even if you're feeling well, because sometimes it turns out you're not doing as well as you thought you as well as you could be. And that's the important role of a regular doctor visit. Very important, and we're going to talk a little bit later, is the medication plan. Have a medication plan. This is also known as an asthma action plan. Again, found found on the ALA website. This needs to be something you understand and you implement on a regular basis. Make sure those medications are refilled and on hand, and you're not scurrying around at the last minute to get a refill. Know how to use inhaler properly. This disease is being treated now with inhaled therapy with various devices and inhalers, and you need to know how to use them properly. And this can be something you can either find again on the ALA website or take your inhaler devices with you when you do your follow-up visits with your doctor, and you can be taught how to use your inhaler properly. And lastly, stay active, stay slim. Obesity has been associated with asthma, so you would like to burn calories as much as possible to make sure that doesn't happen to you. Next slide. Medications for this disease have come a long ways. Over the many years that I've been treating patients with asthma, I'm impressed with how effective and how safe we now have available for treating this disease. This disease is a controllable, very treatable disease, and it's fairly easy to take the medications that are available for control of asthma. They're mainly, as I said, inhaled, and there are two types in general for treating asthma. The first category is what we call a rescue, or also called an as-needed medication. And all patients with asthma should have this kind of inhaler medication. The second is the category of maintenance or preventative medications. And let's go through those with the next slide, what I mean with these two categories. Next slide. The rescue medications are, again, as also called as needed, are basically bronchodilators. They relax that smooth muscle that tightens around the wall of the airway. It immediately provides relief within 5 to 10 minutes of symptoms of asthma. And again, every patient with asthma should have this available to treat any acute symptoms or symptoms that come on quickly. It also can be used preventatively. So if you have exercise as an important trigger for your asthma, a few puffs, 5 to 10 minutes before that exercise activity can help prevent exercise-induced asthma. On occasion, as a rescue medication, oral steroids are needed. These are short-term. They're used mainly for significant flare-ups of asthma, and the whole goal of the treatment of asthma is to make sure you don't have to use the oral steroids for times of flare-ups. So again, these medications are needed to keep you, are needed when you are in trouble. And we're now going to talk about the medications that people are using for maintenance or to keep you out of trouble. Next slide. These are called the daily controller or preventative medications. The most important and most effective form of medication we have and what it does is reduce the inflammation that Dr. Tantisira talked about as being very important in the narrowing of the pipes or airways. The two categories of anti-inflammatory agents are inhaled steroids, which is probably becoming the leading and most important and useful category of medications for control. But we also have something called leukotriene modifiers, also meant to control inflammation and somewhat the spasming of the muscle. An example of this would be Singulair. And this is used in milder forms of asthma and sometimes in combination with inhaled steroids. We've discovered a category of long-acting bronchodilators. We've mentioned those are in the previous slide. Bronchodilators are generally used for immediate relief, but they've been able to change the molecules such that they last for a long period of time, up to 12 to 24 hours. And so they're being used as a preventative medication. And an example of that is Advair, which has one of these long-acting bronchodilators. And so, and as listed here is our fourth category. These are called combination agents. Again, Advair is an example. It has in it an inhaled steroid along with a long-acting bronchodilator. And these, again, are to be used in a daily way, in a preventative kind of way for keeping you out of trouble. Next slide. For years, we've had a form of immunotherapy or an immune modulator called allergy shots. This has been somewhat useful in patients who have allergies as an important contributor to their asthma. And so this is an old example of something we call an immune modulator. But the exciting part of the year 2025 is that we have a growing number of new immune modulators, and we call these the biologics. And examples of this are Xolair, Dupixent, and there are a number of other ones that have come on the market. These are proteins administered to patients on a weekly or monthly basis, and their attempt is to reduce the inflammation that's so important in the underlying process of asthma. And this field of biologics is very exciting and hopefully is going to make a big difference in the future for many patients with asthma. Next slide. So I've mentioned a number of times that this is a very treatable disease, that we have good control maintenance medications for controlling asthma in those who are affected by it. But how do you know that you're under control? And there's been designed a test called the asthma control test, which I've listed here. It's a 5-item scoring um, uh, uh, questionnaire that asks about various aspects of your asthma, including nighttime awakening, how much your asthma is keeping you from getting your work done or getting your school work done. It asks about how often you're having shortness of breath and asthma symptoms on a daily basis, and how often you're using your rescue inhaler. And then finally, the final question is just in general, how do you rate your overall asthma control? So with these 5 sub-scores, you come up with a total score, and the higher the better. And I really recommend that you be aware of this asthma control test and score yourself and see where you're at. And if you're not scoring, in this case, above 20 or 21, with the highest score being 25, you're probably not under control and you need to seek help to make sure that you are. Next slide. So I'm going to conclude with what I feel is the patient's Bill of Rights. We all as citizens have a Bill of Rights that we expect from our government, but I would like to propose we also have a Bill of Rights if you're a patient with asthma. And the Bill of Rights, in my opinion, means that you should expect from your treatment that you're active, you can participate fully in life and exercise and sports, you can sleep through the night, you can attend school and work regularly, and experience minimal side effects from your medication program. And for sure, you can easily be on a program that keeps you out of the ER or be admitted to the hospital. So your Bill of Rights that you should expect should allow you to do everything you want to. And I would encourage you to make sure that the Bill of Rights here are something that that you're experiencing with your asthma as you move forward in the future, and having taken advantage of this overview of asthma. And so I think I'll pass it on to our next presenter.
Dr. Welch and Dr. Tantisira, well done. Thank you so much. And we want to invite Dr. Morris back on to share here about the American Lung Association resources that are available.
Yeah, thanks, Rita. And I want to keep this slide up to let everyone know that there are resources available. If you didn't absorb all of those amazing talks just now in the last half hour, that you can be reminded of some of these things from the resources that you're going to see there. You see the QR codes there, and they have all kinds of things, both having to do with asthma and also with other types of diseases there. You can see there's some things there, some resources for COPD and lung cancer education and lung cancer screening, et cetera. So I'm going to leave that up for a little bit while we talk. And please, audience, make yourself make these things available to you and to your family members. But while we're doing that, I do have some questions for you from the audience, and in no particular order. One question was interesting, and that's about the connection between asthma and emotions. And so is asthma, when it comes right down to it, is that an emotional disease? Or, can you just kind of calm yourself down and make it go away? Or what's the deal with that?
Well, I'll take a stab at that. I did not, or we did not list emotions as a trigger. And I think the purpose of that is to make sure that it's clear that this disease, although used to be considered an emotionally related disease and brought on by emotional factors, that really has changed over the years. And we're pretty clear that emotions play a minimal role, although can. I mean, emotions leading to anxiety and in the middle of an attack of asthma, I think can certainly aggravate the situation and shouldn't and should be controlled if you have the ability to control the anxiety that comes with it, and that can therefore help your asthma symptoms. But to consider this being asthma being an emotional disease has really fallen by the wayside, and so uh, that's kind of the latest.
I agree with Mike, and I just want to just add a point. So I think that certainly at the level of the individual, emotions play relatively little role in the pathogenesis of asthma. There are community-based studies where community-based stress it does play a role overall, and so, there was a study in Chicago, for instance, where if you lived in neighborhoods where there were gunshots frequently heard and things like that, the incidence of asthma is higher at the community level and may be influenced by overall stressful situations. But I think that that's different from the individual emotional type of role that has been classically purported in terms of asthma.
Great. Another question came up that Dr. Welch, I believe you have mentioned steroids. And the question is that we've heard about weightlifters and athletes taking steroids to get, all muscled up and everything. Is that the same thing? Is that a side effect of taking inhaled steroids? Or something like that'll happen?
The history of the use of inhaled steroids came out of when corticosteroids were discovered, and they were used orally in treating asthmatics, and it did a wonderful job, but there were side effects that came with oral steroids. We're all aware of that. So for years they've worked on developing a way to inhale the steroid and delivering it directly to the lungs. And the risk of side effects from steroids now are minimal and totally different than the notion of the side effects from oral cortisone. And the type of steroid that's being inhaled is not an anabolic steroid, so there's no chance that you're going to turn out to be a weightlifter as a result of your inhaled steroid. So I guess that's the bad news, but the good news is that the side effects of inhaled steroids are quite low, and patients can do well even on long-term use.
Dr. Tantisira, a question came up from your slide about the number of cases and et cetera. And one of the boxes there was people dying. And
Yeah.
could you tell us a little bit? I mean, can people really they die from asthma? And is there something that somebody that has asthma now can do to prevent that?
Yeah, so the answer is, as I mentioned, people do die from asthma. The asthma death rates are actually pretty low. As I mentioned, it was about across the United States, it's about 3,600 on an annual basis, and that's out of over 28 million individuals that have asthma. And so it's a very, very, very small portion of that. I think, as Dr. Welsh alluded very carefully to the fact that there are a variety of treatment regimens available for that, and appropriately treated asthma virtually never dies. And I think that if you have asthma, the goal is to actually ensure that you are properly evaluated and properly treated, which is the single most greatest thing in terms of prevention of both hospitalizations and obviously of progressing to mortality.
A question came up related to that is would breathing exercises would that help like kind of just strengthen the breathing muscles and then you're less likely to have this sort of thing?
So I think that that's a complex thing. I think we as asthma physicians always encourage people to exercise, and exercise is just good for overall lung health per se, on top of your asthma control medications. And as we stated, you know, there have been clearly a number of world-class, top of the world athletes that have had asthma, and their asthma being controlled allowed them to achieve the highest peaks of asthma. There are times when, if you are really sick and have been you know, for whatever reason, have not been exercising, there are programs called pulmonary rehabilitation programs that actually can help to increase your exercise tolerance and your overall ability to live with asthma and other obstructive lung diseases.
Um, and maybe Dr. Welch, you could chime in as well. I think this question was about, you know, could like breathing exercises themselves, you know, blow against
Yeah,
resistance or
yeah.
inhale or something like that. Will that help?
Yeah, that's a common question I've had over the years, and I wish I could say yes to that, but there's really not much evidence where it's been proven and it's been tried in the past of seeing if this makes a difference, and unfortunately it really hasn't. And so I think I agree with Dr. Tantisira that the best thing you can do is just make sure you're fit and you're in good shape. That's probably the best thing you're going to be able to do. But breathing exercises of any formal nature are really unfortunately not beneficial.
How about could a person change their diet, and would that change things if they had adopted a different diet? Would their asthma go away?
Well, I will take that on.
Okay.
Um, I think relative to the other treatments we have to help your asthma, if diet makes a difference, it's probably pretty low and comparatively. Um, there's no reason not to try some of the diets that make some sense. For example, the anti-inflammatory diets are worth a try, but it just really hasn't been clear yet at all that diet is playing an important role in asthma. So um, maybe that'll change in the future because we really don't know.
I would, I mean, there have been also a lot of studies to look at diet in terms of, can we prevent asthma by changing diet or by supplementing things? You know, that literature is, there's nothing that ever has come across as this is an absolute cure-all or absolute prevent-all type of factor. And people have looked at a wide variety of things from diet to vitamins to other anti-inflammatory type of therapies. There are some that may be a benefit, but nothing that as Dr. Welsh mentioned is really dramatic in terms of overall prevention as well.
So this is a question from parents saying that, well, if the parents worried about their children developing it, they don't have asthma now. Is there something that they can do ahead of time if that would sort of alleviate the risk?
So I think a lot of the traditional risk factors, I mean, one of them is that we mentioned family history is actually strongly associated. When you look at genetic studies, somewhere between about 30 and 70%, so roughly around 50% of asthma is partially determined by your genes, and then the rest of it is determined by the environment and the things that you breathe. So I think that there's obviously not much you can do with the genetics that you have along those lines. And then many of the factors that have been associated with asthma are things like, you know, having severe respiratory infections as a young kid and things like that. And that those are really kind of hard to control. I mean, you kind of either get them or you don't get them. I do think that having a good perspective as to things like early allergic sensitization and things along those lines, and Dr. Welch can better comment on that as an allergist than I can as a lung doctor. But those types of things are, there is an allergic sensitization process that we call, the allergic triad with eczema, rhinitis, and asthma that may play a role in the later development of asthma.
Great. Now there's a question about whether swimming would help. What's the effect of swimming on if you have asthma? Would swimming help reduce the flares if you made a regular habit out of that? Or is that different than other types of exercise?
Yeah, that's a very common question, Tim, and it's similar to what I talked about with breathing exercises. That again, it hasn't really been shown to be useful, but it is in one way useful in that it's a sport that causes less exercise-induced asthma than some of the running sports. And so for that reason, a person who wants to, take on a sport and have, the less risk of exercise playing a role, swimming is a great sport. And it turns out that's why we have, and I think Dr. Tantisira mentioned a number of Olympic swimmers who have asthma, and it may be that they chose swimming because they have asthma and it was less inducing of asthma.
Great. So we had mentioned triggers. I think you had a slide on there about different types of triggers. I have a question about what about something like a cold or upper respiratory tract infection? Can that cause asthma? And is it a permanent thing or a temporary thing? Would you call that asthma?
I think that the answer is that upper respiratory infections are, for most people, probably the most common trigger for asthma if you have an established asthma. And there are a lot of studies trying to determine if recurrent respiratory infections in young children are actually lead to asthma, and that's a much different question. But the short answer is that it's a very common trigger for asthma symptoms.
Mike, comments?
What's that? Oh, comment on that? Yeah, it is the number one, especially in kids, the number one trigger. But whether the infection itself, and that's in a patient with asthma, but whether the infection itself actually creates asthma is generally not true, except for the timing as to when the infection occurs. And as Dr. Tantisira said, early on, there's this thing called respiratory syncytial virus or RSV that has been linked to the child then going on later on in life after they've had their RSV infection in the first couple years of life, leading to asthma. So whether that's a direct cause or other, factors have to be kind of in place with that, we don't really know, but that's the one infection that we could sort of kind of say it could lead to a picture of asthma.
There's another question about the relationship between acid reflux and asthma. And number one, if a person has acid reflux and they're symptomatic, and maybe if they have a family history of reflux, should they be more on the alert? So what's the connection between those two?
So having bad acid reflux can certainly lead to symptoms that are very similar to asthma. As you might imagine, acid reflux just basically means that either acid itself or acid vapors are coming from your stomach up into the airway and potentially getting down into your airways. And obviously that's a scary thing. And your airways are actually very protective of themselves. And so if you're breathing in acid vapors, one of the things that they rapidly do will want to bronchoconstrict or have those airway smooth muscles close around to protect too much acid from getting down into the lungs. And so a lot of times those can mimic symptoms. You can cough as a result of acid reflux, and you can actually wheeze as a result of acid reflux as well. It doesn't necessarily cause asthma by itself, but certainly it can worsen asthma symptomatology.
Will the same types of medicines that work for a asthma exacerbation or an asthma episode, will they help if the problem is a reflux brought it all?
So you can use bronchodilators, but obviously the goal for acid reflux is to actually treat the underlying cause, which would be to try and see what you can do in terms of either antacid therapy or other additional therapies to prevent the reflux to begin with.
There's a question about pulmonary rehabilitation, and maybe you both of you could describe a little bit about what that means, and then talk a little bit about whether what the potential is for that helping people that have asthma.
I'm happy to take it, or Mike, go ahead if you
Yeah,
want.
no, go ahead. No, go ahead, and then I'll comment. Yeah.
Sure. So pulmonary rehabilitation is a little bit different than rehabilitation, for instance, after you break your leg or something like that, which is more physical rehabilitation. And that really says, okay, well, your leg, you haven't used it for a long, long time. What can we do in order to strengthen your leg after you've broken it, build up your muscles? Now, the principles are the same, but pulmonary rehabilitation really does focus a lot of emphasis on how can we breathe better in order to improve your functional quality of life and improve your exercise tolerance overall. And I think that you see that happening in a lot of instances. The most common disease state that uses pulmonary rehabilitation is probably chronic obstructive lung disease or severe COPD or emphysema that uses pulmonary rehab. And that's it, pulmonary rehabilitation for those patients who have severe COPD has clearly been shown to increase quality of life and increase exercise tolerance overall, although it hasn't had a lot of other I'll just leave it at that. It's very, very positive outcomes in terms of exercise tolerance and quality of life. Asthma, does not typically fall into that type of disease overall, where you get to the point where you need pulmonary rehabilitation to increase your exercise tolerance or quality of life, because you can often achieve that in other ways, which is asthma, by definition, one of the things we did not mention in the definition, but classically, it's a reversible airflow obstruction as compared to COPD, which often is irreversible airflow obstruction. And so the goals for asthma management is to say, how can we reverse your airflow obstruction so that you don't need pulmonary rehabilitation and you're optimally treating to begin with?
Dr. Welch, do you use pulmonary rehabilitation or something like that for your asthmatic patients?
No, the patient with fairly pure asthma without COPD in the picture generally is not going to benefit from pulmonary rehab. But so often, adult patients who have asthma can also have COPD. And that mixed kind of bag of COPD and asthma, that when it's severe enough, could lead to a situation where a patient would benefit from pulmonary rehab. But again, the COPD part is really what makes them a candidate.
Great. There's a question about the effect of e-cigarettes and vaping, and so I think we're all familiar with the fact that smoking, this smoke from a cigarette, is bad for your lungs. But is a way around that, if somebody wanted to get the nicotine, is to use like a vape, to vaping or use an e-cigarette? Does that avoid the damage to your lungs related to asthma?
I'll take that first. Um, People hoped maybe that could be the case when these electronic cigarettes came out, but it's becoming clear that's not the case. And patients with asthma should not feel that just because they're avoiding an actual cigarette and going to a device is going to help them avoid the irritant effect of smoking, they're wrong. And so that's got to be a point of education that has to occur, especially in the teenage population, with kids who have asthma, that the e-cigarettes are potentially a fairly potent trigger for their asthma, and they need to be avoided.
Dr. Tantisira?
Yeah, no, I agree with that. I mean, I think it is really the irritant effect, and while it avoids maybe some of the chemicals in from cigarettes, there are other chemicals that actually do get down into your lungs even while you are vaping, and those chemicals may have independent effects even over and above the irritant effects. So compounding the effects for sure.
Great. A couple of questions about breathing tests. One about the peak flow meter that a lot of people have, in their homes, and the other is about the things that the more advanced and sophisticated tests that happen in doctors' offices and in hospitals. Could you comment about those? I didn't hear much about those. Are those useful? Is one useful, more useful than the other, or what's your approach to that?
Do you want to start, Mike, or I can start either way?
Yeah, you start, and then I'll add some things because
Sure.
I have some feelings on this.
There you go. So I think that you know I will take a step back and say when asthma doctors look at things, historically there have been two broad sets of guidelines that we use to help determine when and how to treat individuals. And historically in America we used the North American asthma guidelines, but those actually have not been updated for many years. And one of the key aspects of those North American guidelines was they actually did include lung function or peak flows as a criteria to assist with treatment. I think most individuals in the asthma specialty domain these days have transitioned to the global guidelines for asthma, which are actually used in about 150 countries now, and including most specialists in the US, and they're actually updated on an annual basis, and they very much focus much more on symptoms control rather than focusing on lung function per se. I will say that lung function tests are helpful to me in terms of initial diagnosis of asthma, in case if you have other things that are on your mind that you're saying, well, this person may have a chronic cough or they may be wheezing and we're not quite sure why. And if you do see a reversible obstructive, what we call an obstructive defect on your fancy breathing tests, then that can help with the diagnostic aspects of things. And I think that following lung function on a day-to-day, week-to-week basis these days is may not necessarily be seen as helpful. I think for individual patients, peak flow meters can be useful if you feel that it's an additional way of determining how bad and how serious do I feel. So I think that sort of is my take on things. But obviously, Dr. Welch, it is, as mentioned, just from having the two guidelines that even differ on use of lung function, people do view these things somewhat differently.
Yeah, no, I agree with it. I have feelings I just want to point out to patients with asthma, or that patients with asthma, they have a lot to do to take care of their asthma. It's called the burden of asthma. And we were in older guidelines asking them to do peak flow monitoring on a daily basis. And it turned out, when studied, probably what it wasn't necessary, and that symptoms are most important rather than these readings on this thing called the peak flow. However, as you said, Dr. Tantisira, there are some patients who are kind of not aware of their symptoms, and the peak flow meter can sometimes give you a number that tells the patient that perhaps you should be taking some action that they otherwise would not take, because they're ignoring or they're tolerant of their symptoms, and which can get them into trouble. But so yes, on an individual basis, I think the peak flow meter may play an important role at home with patients having control of their asthma.
There's a question about the drugs that you mentioned, Dr. Welch, that there are some drugs that we're used to saying that, for instance, pain medications you develop a tolerance to. It's probably not a good idea to overdo pain medications, and maybe the same for antibiotics. It's probably not a good idea to take a lot of antibiotics if you don't need antibiotics because the bacteria develop a resistance to them. Is it the same thing with asthma medications? Do you need to kind of watch it so that you don't overdo it?
Very good question, often asked by my patients. The general overview answer to this is no. It's not like the kind of medications that you talked about. But let me say this. We start patients on a certain dose of whatever, inhaled steroid, for example, and they've obtained control and they're using it. And so one of the goals of treating a patient with asthma is to get down to the lowest dose that controls them. Not that we're worried about necessarily that they're going to become, addicted to the medication, but just because we like to keep the maintenance medications down to a minimum. And so that's for that reason we may lower a medication program over time. But the good news is, in general, with the maintenance medications that patients take on a daily basis, we don't see this kind of tolerance that you see with other medications. The rescue medication of albuterol, when used at really high doses, this sometimes can become a medication that quits working, and you do kind of become tolerant to it, and that's where the patient can get in trouble. But that's only at high doses.
Dr. Tantisira, do you see the same thing?
Yeah, I completely agree. I think that speaking from the perspective of a pediatrician here, we're doubly careful about trying to minimize the effective dose, because I think we just don't want a lot of medicine given to children. But the long-term studies have all shown that there aren't really dramatic long-term effects that you have from these medications in terms of side effects. I will echo what Dr. Welch said about the beta agonist or the short-acting medications, that they can stop working, or work very much less well if you are using them repeatedly by themselves. And actually, that's why we do encourage individuals that if you're taking your rescue inhaler, every day, multiple times a day, you would likely benefit from being on a controller in addition to that. And I do think the other thing that is trending is that some of the newer guidelines suggest that you might want to use a controller inhaler at the same time you use the short-acting rescue inhaler to A, because it helps prevent things like worsening of attacks, but B, it may help a little bit with this getting used to the medication effect as well.
I have another question in the QA about from a person who's had some asthma-like symptoms, or at least shortness of breath after a cold or a respiratory illness, and was expressing a little bit of frustration because they were getting different answers about whether that was asthma or not. And some of the symptoms would last for a few months and then they would go away and they respond to medications, et cetera. But how can, obviously people want to know the answer to what's going on with them. If you have a patient in that situation, what do you usually advise them to sort of pin down what the problem is?
Let me give my feeling on this. This is common. This happens pretty often in adults, particularly. And what I use to determine and sort it out is a couple of things. One is, did they have asthma as a child? Because often asthma will improve as you grow older, but it'll come back and visit you, especially when you get an infection. And so if they have a previous history of asthma, then I would be worried that their asthma has returned. And the second is they should try a trial of a little rescue bronchodilator. And if that's helping, then you're probably barking up the tree of asthma rather than otherwise. Although again, this infection could be also playing a role at the same time, so it's a mixed picture. But I would say previous history of asthma and response to a bronchodilator can be very helpful in this situation.
Maybe a related question is at what point would somebody who's maybe getting a little frustrated with that, at what point would it be appropriate to do some of these more advanced tests you were talking about, or maybe see an asthma specialist?
I mean, I think the point is probably anytime you really don't feel comfortable with what your primary care physician is saying and you're not unsure what your symptoms really represent, I think that that's perfectly a reasonable time to say, hey, can I be referred to a specialist to determine if this chronic cough is indeed asthma versus something else. There certainly are some specialized tests that are can be done to help better delineate whether things are asthma or not, but that those tests are also best interpreted by a specialist as compared to just ordering the test and having the test go back to the primary care provider. So,
Like how many, same question, but how often do you think it's the case that the diagnosis is enough of a mystery that it would be helpful to get somebody like yourself who's a specialist in this and can help with the sorting through what's going on?
Well, I think that's, as he mentioned early, if the patient is frustrated and it's been going on for a long period of time, it's probably time to ask for a second opinion. And the pulmonary function test that can be done by the specialist, I think, may help a lot in sorting out what's going on. So I think the you know how long something's lasting, I don't know, 3 weeks, 4 weeks, 5 weeks. I think it's time to call in some help.
Great. Well, like most friendly gatherings, I wish it was could go on forever, and I would certainly love to keep on doing this, but the time has just flown by here. So our time is up, unfortunately, for this fascinating conversation. Let me thank you, Dr. Tantisira and Dr. Welch, for a fabulous presentation and a really very interesting discussion afterwards. I would also like to thank our technical people, the volunteers Rena Ding and Lin Zhang, who are the ones who are responsible for a lot of the technical aspects of this, and they're doing this as volunteers for the Lung Association. And speaking of the Lung Association, thanks to Rita Rodelli and Micheal Gonzalez, who helped arrange this whole thing. Thank you to the audience members for your attention to this. Again, if you'd like to see this or any other of the community connections presentation that we've had, you can go to our website and see them, and stay tuned for more of the same. Thank you very much. Have a great night, everyone.